Okay. Okay, so let me see if it is a full screen. Okay, so there's a slight change in the title of my talk. Initially, it was GLP-GIP dual agonist, but I will briefly mention about the triple agonist. So I think the appropriate title will be unimolecular polyagonist in management of diabetes and obesity. So I start with a case. Can you see the slide changing?
Yeah.
Yeah, there.
Okay. So I start with the case which I see in my clinic, and he's a middle-aged male, which is obese male, has a long-standing history of type 2 diabetes, is on high dose of insulin, and is also on SGLT2 inhibitor, and has an extensive history of cardiovascular disease, and has multiple stents. And his A1C, current A1C is 8.2%, as he has chronic kidney disease, and he wants to achieve better glycemic control, but he's very concerned about weight gain. So what will be the appropriate choice in therapeutic option in this case? So we can increase the dose of insulin, but it will lead to weight gain. And DPP-4 inhibitors, these class of drugs have very modest improvement on glycemic control and have no effect on weight. And pioglitazone can lead to weight gain. So obviously the choice will be a GLP-1 agonist. And he was in fact started on a GLP-1 agonist. I'll tell you which one. And 8 months later, when I see him in the clinic, his current A1C is 5.9%. That is in the pre-diabetes range. And he no longer is on insulin. And he's lost 50 pounds of weight, which is more than 20 kilos, about 20 kilos. And his eGFR is stable. So, and this kind of efficacy with the anti-diabetic agent, we have not seen before. And he was in fact started on a drug called tirzepatide, which is GLP and GIP agonist. And this class of drugs, is comparable. The efficacy is kind of comparable to that you see following a bariatric surgery. So, as for guidelines, patients with pre-existing heart disease, I think other previous speakers have mentioned that pre-existing heart disease, you start with the GLP-1 agonist, particularly those of atherosclerotic heart disease, or those of heart failure, you start with a SGLT2 inhibitor. So we currently have several GLP-1 agonists available in the market, including the oral GLP-1 agonist, Dr. Das mentioned. But the limiting factor of GLP-1 agonists is that the adverse events, they're very potent. They're lower A1C by 1 to 1.5%, and semaglutide on higher dose can lead to weight loss about 15%. But the limiting factor, again, is the GI side, mainly the GI side effects. So
slides are not moving, I think.
Okay, slides not moving. Okay. It's moving now? Is it moving?
No.
Okay, it's moving on my end. Okay, let me just restart it.
Reshare will be better.
Okay, can you see it now?
No, yeah, now it has come.
Okay.
Yes.
It's moving?
Yeah, moving. Yes.
Yeah, it's moving.
Okay.
It's moving very well, Devjit.
Okay. So that's the limiting side effect of the limiting factor in GLP-1 agonist treatment is the GI side effects. So one strategy is that if you could add.
Can you make it full screen? Full screen.
Okay, is it done now?
No.
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 And why is that? Okay. Okay. Is it okay now?
Now it's done. Yeah.
Okay. So yeah, the one strategy is to combine with another agent, which will with the GLP-1 as a foundation, and then target other pathways like lipid metabolism or insulin sensitivity. Because GLP-1 agonists do not have a direct effect on insulin sensitivity or do not affect the lipids much. So And how about the GIP? No, GIP is a glucose-dependent insulinotropic polypeptide, and it's another incretin. And in fact, the endogenous GIP accounts for majority of the endogenous incretin effect. It's more important than GLP, the endogenous GIP. However, the GIP secretion is found to be normal in patients with type 2 diabetes. And early studies shown that if you infuse GIP to patients with type 2 diabetes, you do not see any effect on insulin secretion or improvement of glycemia. And the animal studies, earlier animal studies are controversial, like if you knock out GIP receptor, there were some studies that shown actual weight gain, some studies show weight loss. So therefore, the GIP agonists are not pursued for management of type 2 diabetes. All the studies were mostly on GLP-1 agonists because GLP-1 agonists are very potent in weight loss and improving glycemic control. However, recently, it has been shown that in animal models, if you overexpress GIP, it leads to weight loss and improved glycemic control. And if you infuse combined GLP and GIP to patient type 2 diabetes, it's shown to be an additive effect in terms of insulin secretion, and but not on weight loss, just insulin secretion. However, it's not practical. You cannot combine and give two separate infusions or injections of GLP and GIP. So there's the possibility of a single molecule, which is both GIP and GLP, was being explored. And here it shows the compare and the contrast the effects of GLP and GIP. And on the left is the GLP. And here, the both increase satiety or decrease food intake. That's how they cause weight loss. The difference is that GLP-1 actually increases nausea, whereas GIP actually decreases nausea. So if you combine GLP and GIP, then you expect that this will attenuate the adverse events of GLP-1. The other major difference is that GLP-1 reduces glucagon, whereas GIP increases glucagon, particularly in hypoglycemia and euglycemic settings. And another major difference is the effect on adipose tissue, because there's no GLP-1 receptors in the adipose tissue. So GIP has the effect, it's kind of mimics that of a thiazolidinedione. It improves adipose tissue insulin sensitivity, storage capacity, and the inflammation in the adipose tissue. That's why it can improve both adipose tissue and skeletal muscle in insulin sensitivity. So therefore, if you combine, so the newer strategy is to combine two molecules, because instead of giving two different injections, if you combine one molecule which can act on both receptors, that will be much beneficial. And it's called unimolecular multi-agonist. So single molecule act on different receptors, or it's called hybrid molecules. So the hybrid molecule that is being now developed, or some of them are already in clinical trials. For diabetes, there's one combined with GLP and GIP. There's another one, glucagon. Glucagon and GLP-1, they're combined because they're both derived from the same pre-pro-glucagon, and they're homologous amino acid between GIP, GLP, and glucagon. That's why it's easier to develop a molecule which acts on all three receptors. And the benefit of hybrid molecules is that they confer the beneficial effect to each, like GLP and GIP, and they can counteract or offset the negative effects of GLP. So, for example, in GLP causes increased nausea, GIP causes less nausea. So that's why you can increase the therapeutic windows for the GLP-1. So you can give higher dose without any side effect. And the other benefit is the single pharmacokinetic profile, because this is just a single molecule. And this is particularly important in patients who have chronic kidney disease, and those who have liver and hepatic disease also. And they have single molecules which acts on multiple effects on the single target organ. For example, in the pancreatic beta cells, both GLP and GIP increase insulin secretion from glucose-dependent insulin secretion from the beta cells. That's how they can increase insulin secretion, have a complementary effect or additive effect on insulin secretion. So these are the schematics showing the polyagonist that are being now pursued for treatment in type 2 diabetes and obesity, GLP and glucagon. And I will not talk much about it because there's one drug developed by AstraZeneca. It's called Codatutide. And they went to phase 2 trials, then somehow, for some reason, they decided not to pursue. So there's currently right now, there's no drug being developed, but there's some drugs by Novo. They're pursuing it for treatment of NASH. And I will show details about the tirzepatide, which is the GLP-GIP, the only approved GLP-GIP co-agonist. And I'll show some data of the triple agonist, GLP-GIP and glucagon triple agonist. So these are the structures of native GLP-1, and this is GIP. GLP-1 has about 30 amino acids, GIP has 42, and this is tirzepatide, which is 39 amino acids. And tirzepatide is a peptide which is basically has the backbone of GIP. It mainly acts like a native GIP. And in vitro studies have shown that this is more similar to native GIP in terms of efficacy in animal models and binding affinity and cyclic AMP generation, and is less than native GLP-1. And the half-life is 5 days, so you can eat, that's why you can have a once a week dosing. The structure of tirzepatide, the top one is GLP-1, then the GIP, then this is exenatide, the first GLP-1 agonist approved for the use in humans. And this is tirzepatide. So you can see those in light blue. These are the amino acids shared from GLP and GIP. So tirzepatide contains 9 amino acids derived from similar to that in GIP, about 4 amino acids derived, which is common to GLP-1, and about 10, which are common to both GLP-1 and GIP. So it has a lot of amino acids which is similar to GLP and GIP, and there's some from similar to exenatine. And is bind to fatty acid, which binds to albumin, that's what prolongs its half-life. So this structure has a lot of similarity between GLP and GIP, but mainly more close to GIP than GLP-1. And in vitro studies have shown that it's equivalent to native GIP in terms of cyclic AMP generation, because both GLP, GIP, and glucagon, this class of drugs, they act on the G protein, this called G protein coupled receptors, which generate cyclic AMP. And you measure the amount of cyclic AMP to measure the activity of these compounds. So it is equivalent to native GIP, but much less than native GLP-1, 24 lower cyclic AMP than native GLP-1, and 5 for lower binding affinity than native GLP-1. Again, but these were the animal studies and in vitro study. In human, what happens, we do not know. So they're the first in human studies. It was published as early as 2018, and showing that type 2 patients treated for 6 months with this compound. That time it was known as LY32981, and showing that the red one is dulaglutide as compared to GLP-1. And over a period of 6 months, while dulaglutide causes lowering of A1C by 1.1%, the high dose of tirzepatide led to hemoglobin A1C lowering of 2.4%. And the weight loss was similarly over a period of 6 months, 11 kilogram weight loss with the higher dose compared to 2.7 kilograms with dulaglutide. So as of all available anti-diabetic agents, as of now, this appears to be the most potent agent in terms of lowering hemoglobin A1C and body weight. So I'm not going to go through individual studies. There are like 5 SURPASS trials, SURPASS 1, 2, 3, 4, and 5. And most of them have kind of similar design, just the comparator is different. Also a summary slide, which shows, so this is the phase 2 studies compared with, and then this is the SURPASS 1 with placebo, and then SURPASS 2 compared with semaglutide, SURPASS 3 compared with insulin degludec, SURPASS 4 compared with glargine and patient with high-risk cardiovascular disease, and SURPASS 5 again compared with insulin glargine. So as you can see, compared to placebo, this is the baseline A1C slightly low. There's reduction of 1.5 to 2%, but all of the studies consistently shown that there's A1C lowering where in high dose ranges from 2 to 2.4%. And it is greater than semaglutide. This is semaglutide, but this is not the high dose semaglutide. This is semaglutide 1 milligram, which leads to hemoglobin A1C lowering about 1.7%. And this tirzepatide showed a greater A1C improvement compared to semaglutide. Not only that, in about 40% of patients with high dose tirzepatide, it leads to A1C lowering in the non-diabetic range, that is between 5.7 to 6.5. As we discussed a little bit earlier about metabolic memory, so if you can induce euglycemia in a patient with type 2 diabetes, that will have a long-term effect in terms of reducing complications, although those data are not available yet. And it is more beneficial, more effective than patients on insulin. This is insulin degludec, and this is insulin glargine. Again, both are insulin glargine. So consistently shown A1C lowering 2 to 2.4%. The bottom panel shows the effect on body weight, and again showing the 8 to 10 kilogram of weight loss, which is about 10 to 15% weight loss. Again, no other drug leads to that weight loss except semaglutide high dose 2.4 milligram can lead to 15% weight loss. And again, consistently shown about 10 kilogram of weight loss, which is about 10% of 10 to 15% weight loss. So overall, this study, tirzepatide causes about 2% lowering of A1C and 10 to 15% weight loss in patient type 2 diabetes. And how about adverse events? The basic premise was that if you combine GIP, you will should not see much side effects. However, that was not seen. But as with any GLP-1 agonist, the adverse event is seen initially in the first 4 to 8 weeks of treatment. And here, this is compared with this is the semaglutide. This is tirzepatide 5, 10, and 15 milligram. You can see that for the higher dose, so there's a dose-dependent increase in adverse events, particularly nausea and vomiting. And however, it's seen earlier in the first 4 to 8 weeks. So the plan is, or the recommendation is to start low and go slow. So you start with 2.5 milligram and go by every 4 weeks, you increase by 2.5 milligram. If you go slow, the risk of side effect is slightly lower. But what was disappointing was that this was not really different than semaglutide. So although we show that this drug causes greater weight loss and A1C lowering, but you still see the similar kind of nausea and vomiting as you see with semaglutide. And here the bottom panel showing the vomiting, you see the similar data. So summary, the tirzepatide is SURPASS-2, but is similar to all of the studies, leads to about 10 kilogram weight loss and improved A1C, and also improves the triglycerides, lowering about 25 to 30%. It does not affect much of the LDL, and the HDL goes up by about 7%, 7 points. And the adverse events are comparable, not less or not higher, but it's comparable to other GLP-1 agonists. Now, this is a study on patients with non-diabetic obese patients. This drug is not yet approved for obesity, but a lot of people are using this as off-label use for obesity. And so in non-diabetic obesity, it shows a greater weight loss, 20%. This is consistent across all studies. You see greater weight loss in non-diabetic subjects than diabetics. One theory is that for each 1% lowering for A1C, you gain about 2.2 kilogram because you reduce the glucosuria. And that's a theory by Aki Arvinen. And but with now the onset of with concomitant treatment with SGLT2, we don't know how true that is. But that is one theory, that you always see a greater weight loss in non-diabetic compared to diabetics, any drug. And about 90% individual lost more than 5% of body weight, which is the requirement for approval of any anti-obesity drug by the FDA if you lose more than 5%. And based on this data, everybody, almost 80 to 90% lost more than 5% body weight. So cardiovascular events, this study was not powered to look at the cardiovascular benefits, or just about for the FDA requirement, you have to show that it does not increase cardiovascular risk. So from this, you can conclude that it does not increase cardiovascular risk. Only in the higher dose, 15 milligram, there's a trend, but again, the event rate was very low. So you cannot conclude whether it's cardiovascular benefit or not. One can conclude that there is not increased cardiovascular risk, both in SURPASS-4 as well as other SURPASS trials. So how does this drug work? How is so potent compared to other GLP-1? There's several theories. Nothing has been tested in humans yet. The mechanism of action of this drug. The animal models does not always translate to that in humans. And one theory is that possibly GIP agonism acts to GIP, so there's an additive effect of GIP. Another theory is GIP enhances the effective of GLP-1, or GLP. If you start with the treatment of GLP-1, you achieve euglycemia. Several studies have shown in humans that once you achieve euglycemia, the GIP can be effective. So possibly that initially you see the GLP-1 effect, then subsequently the GIP effect is observed. And there's who believe that this drug is nothing but just a very potent GLP-1 receptor agonist. So, but the human studies are not done yet. We are proposing to do one so that you can blocking one receptor, see if you can still see the effects. Another theory is that GIP enhances the lipid buffering capacity, that is a thiazolidine-like effect, which is not seen in GLP-1 agonist. And possibly there's an increased weight loss in tirzepatide. Again, it's in most weight loss, not because of energy expenditure, but because of decreased caloric intake. And that is one theory, that there's increased effect of both GIP and GLP and both receptors and hypothalamus. You see increased effect on satiety on the combined GLP and GIP versus single, only GLP-1. And again, there's a weight loss intermittent insulin sensitizing effect of this drug, likely to the adipose tissue. So there's one study looked at the mechanism of action, but again, this was in obese mice, and it showed that there's a weight-independent insulin sensitization by tirzepatide. Again, we discussed it could be like a like thiazolidine-like effect of GIP. And this is the only study which looked at the mechanism of action in humans. What they did was in Germany, they performed euglycemic clamps followed by hypoglycemic clamps in patients randomized to placebo, then one group randomized to semaglutide, one is to tirzepatide. This is the effect on the clamp-induced disposition index, which is a marker of beta cell function, showing that patient on the green column, showing that they are higher, greater improvement in beta cell function, those who are on tirzepatide for 6 months. And it shows the clamp insulin data at baseline that is similar. This is a hyperglycemic clamp. Here is the first phase insulin response. This is the insulin response following arginine. In a hyperglycemic clamp, this is the second phase insulin response. And showing that the red is the one with semaglutide, the green one was tirzepatide. At baseline, there was no difference in insulin response. However, after 6 months of treatment with semaglutide or tirzepatide, you see a greater effect on first phase insulin response, second phase insulin response with tirzepatide. And there is a greater, here again, confirming that the first phase insulin response was higher with semaglutide. The second phase tended to be slightly higher. Again, the insulin sensitivity was higher with tirzepatide. But again, there was a greater weight loss with tirzepatide than semaglutide. So the weight loss could be contributing to the improved insulin sensitivity. So to summarize that, tirzepatide is superior to semaglutide in terms of improving insulin sensitivity. But they have looked at the change in insulin sensitivity in the weight loss. So with the similar weight loss, semaglutide, tirzepatide led to a greater improvement in insulin sensitivity than that of semaglutide. It improved better improvement in beta cell function. And also, even though there's a GIP component here, there's a greater suppression plasma glucagon with tirzepatide than with semaglutide. That could also be contributing to improved glycemic control. And the side effects are comparable to GLP-1 agonists. So overall, tirzepatide is very effective in terms of lowering glycemic body weight and improving glycemic control. The mechanism it does by improving both insulin sensitivity and beta cell function. And the synergistic effect of GLP and GIP, that it increases insulin sensitivity, insulin secretion, improves triglyceride clearance, and that's what plasma triglycerides is markedly reduced and possibly decreasing lipolysis, and increased fatty oxide and decreasing lipolysis. And here, possibly by decreasing postprandial glucagon and decreasing hepatic glucose production. Again, not all of them has been yet proven in humans. This is a hypothesis. So now, changing gear to glucagon. So we all know that glucagon is a drug which is the primary effect of increasing hepatic glucose production. So we use it for treatment of hypoglycemia. So it's counterintuitive to see that how glucagon can be used for treatment of type 2 diabetes. Now, glucagon has also effect on beta cell. If you give a glucagon, we do that called glucagon stimulation test to see insulin secretion. If you give acutely, glucagon increases insulin secretion. It has effect on the hypothalamus, decreasing appetite, increases energy expenditure, which is different than that of other GLP-1 agonists. They increase satiety and have no effect on energy expenditure. They increase fatty acid oxidation. That's why it's effective. They're being pursued for treatment of non-alcoholic steatohepatitis or NAFLD. And they also decrease gastric motility, and they increase postprandial amino acid uptake. So the rationale for combining glucagon is because of these effects. So if you can increase energy expenditure, increase insulin secretion, and by combining a slightly glucagon-like activity in turn with GLP and GIP, you may see an additive effect. So, and of note, both glucagon antagonists and agonists are being developed for treatment of type 2 diabetes. In fact, we did a study on glucagon antagonists, but that drug is now being no longer being developed because it has some hepatic side effects. But the other glucagon antagonists are being tried also. So again, I just showed you GIP has effect on adipose tissue, improve insulin sensitivity and regulation of lipid metabolism. Its effect on appetite. It has no effect on energy expenditure, increase insulin secretion, and increase glucagon. And GLP-1 mainly acts on the CNS, decrease appetite, insulin secretion, and delayed gastric emptying. And glucagon has energy expenditure delayed, decreases appetite, increases appetite. So, and also causes increased fatty acid oxidation. So So these are the two triple agonists that is being pursued in clinical trials. They both were published in Cell Metabolism in 2022. This is a compound developed by Sanofi, and this is a compound by Lilly. And this drug, both these drugs in animal models showed that it improved weight loss and improved insulin sensitivity and insulin secretion. However, for the Sanofi compound was once a day compound, whereas Lilly compound is once a week. So for some reason, this compound they stopped for the development. We don't know why. But the Lilly compound, they've been pursuing phase 2 and phase 3 data. I'll just show you some phase 1b data. This is the data on triple agonist GLP-1, GIP, and glucagon, and it was published last year in Lancet. And this is a small study, phase 1b study, and patient and dose escalating compared to placebo. There are 5 different doses of this triple agonist compared to dulaglutide. Patients with type 2 diabetes and 10 years duration of diabetes were randomized to receive 5 different doses. And as you can see, the bottom line, the dulaglutide is on the blue, and the others are different doses of the triple agonist. And this was only a 12-week study, that is for 3 months. And over 3 months, you can see that there's a decline in A1C by 1.5% with the highest dose of this triple agonist, but other doses shown between 1 to 1.5%. And this suggests that this is not a plateau. If you increase further, maybe for 6 months, you can see a further lowering of A1C. So they are currently doing the 6-month studies. And this is the weight adjusted body weight loss, again showing that 9 kilogram weight loss only in 3 months. But the most remarkable effect was seen in lipids. And here it shows that HDL on the left panel, the HDL actually went down, which is not good, but it was slightly went down, whereas tirzepatide and other GLP-1 agonists increased the HDL slightly. And the LDL, there was a 30% decrease in LDL, highest dose. There's a 40% decrease in VLDL and triglycerides. So that's why these drugs are being pursued now with the compound by Novo for treatment of NASH. And the other beneficial effect just seen in a short study, this is like small number in short studies, so we don't know whether this will be replicated in bigger trials. They showed it 12 to 15 milligram drop, 12 millimeter of mercury decrease in systolic blood pressure. Usually all of the drugs like GLP-1 and SGLT2 inhibitor, you see a single digit drop in blood pressure, maybe 4 to 5 millimeter of mercury, whereas this drug, there's a significant lowering of systolic blood pressure. So overall, this compound over 12 weeks shown a similar safety profile as incretin agonist, improvement in glycemic control and body weight, and showed improved lipid profile. So, and the rationale for development of this drug, that even with a highly potent drug like tirzepatide, about 12% patients in all the SURPASS trials did not achieve control. So there is room for development of the drugs. Not all the drugs will not be good for everyone. So that's a rationale for developing other drugs, because 10 to 12% not respond to even the potent drug like tirzepatide. Although tirzepatide, they showed us effective regardless of the duration of diabetes, the baseline A1C, or the baseline C-peptide level. But still, there are patients who will not respond to tirzepatide. Maybe in those patients, one may try this triple agonist. So to summarize, GLP-1 agonists improve glycemic control, reduce body weight and hypoglycemia. And again, tirzepatide does not cause hypoglycemia per se. And so promising results in both glycemic control, weight loss, and has potential for use in NAFLD and NASH. And actually, we saw the type 1 diabetes studies earlier. They're actually doing some study in type 1 diabetes too. We do not know the results. And they're superior to other GLP-1 agonists. And the adverse effects of tirzepatide are the dual agonists comparable to GLP-1 agonist. And long-term data for tirzepatide, particularly in the cardiovascular outcome data, is still pending. It will be published in the called SURPASS CVOT trial. That will be published in 2024 October, when that trial ends. And the triple agonists, GLP, glucagon, and GIP, they show a very promising role in terms of improving glycemic control or for weight loss. They may be approved for treatment of diabetes and obesity in future. I think that was the last slide. And as I showed, that there are several trials undergoing now but there's no the GLP and GIP in pipeline now, but GLP and glucagon being pursued for treatment of type 2 diabetes and NASH, and GLP, GIP, and glucagon again pursued for treatment of type 1 NASH as well as type 2 diabetes. I think that was the last slide, and thank you. I think we'll wait for the panel discussion for the questions.